Total knee arthroplasty is arguably one of the most instrumented surgeries today. You have alignment guides and surgical navigation and even robotics. However, the soft tissue balance is still an art. The surgeon still relies on his intuition and his own expertise in trying to arrive at the optimal balance for each patient. It began by using spacer blocks, which were some of the earliest balancing devices, and these are still sometimes used by surgeons who do a measured resection. And surgeons that do gap balancing prefer some sort of mechanical tensioners, and these range from laminar spreaders to devices that have been designed specifically for certain instruments or certain implant manufacturers. So my interest in electronic ligament balancing began more than 20 years ago. And what we did was we took a tibial tray trial and we instrumented this tibial tray trial with load cells. So in a sense, it behaved like a spacer block, but it had forces on the force sensors inside the tibial tray. And you could now measure forces as you range the knee in flexion extension. That would give you a sense of the imbalance in the knee. Since then, a company called Synvasive developed a similar device called the eLibra, where they put sensors in the tibial insert, and they used a device that was fixed to the femur, and you could rotate the femur to dial in the appropriate femoral rotation and make your posterior femoral cut. More recently, Ortho Sensor has put in the sensors, has put in force sensors in their tibial inserts. And these sensors measure the forces in the medial and lateral compartments with the assumption that if the forces are equal, then the knee joint is balanced. These sensors are specific to the implant design, and they're not universal, and have been in use for several years now. So the problem with force sensors, we quickly realized, was that the surgeon who was doing distraction, using tensioners for distraction, was actually looking at the gap and didn't know how to translate the forces that were being measured into a surgical technique, a change in the surgical technique, or a change in the bone cut. So what we did was we designed a expanding device that was pneumatically operated and applied a constant pressure or constant force inside the knee joint and measured the gap and measured the angle or the imbalance that was more in line with the surgeon's visual analysis. And we designed it so that you can measure traditional balance, which is done at 0 and 90 degrees, the so-called static balance. You can measure dynamic balance over the entire range of motion. In addition to medial lateral balance, we were also interested in balance in the anterior posterior direction. And we wanted to make the device universal so it could be used with measured resection or with gap balancing. So I'm just going to show you an animation of some examples of how this can be used. Surgeons that typically do the femur first, and these are commonly measured resection surgeons, can use this device at the end of their surgery. So here's an example of a knee that's tight in the medial and posterior direction. And what you're seeing, the display on the right, is the sensors that are recording the tilt between the top plate and the bottom plate, and showing that there's a tightness in the medial compartment in the medial collateral ligament. In such a case, the surgeon can go in and do a release and watch the correction as he performs the release, and then check the balance again, assuming that the release is adequate. So you don't have to keep releasing and testing. You can do it in real time as you're releasing the knee. Some surgeons prefer the tibia first approach, especially the surgeons that believe in gap balancing. The tibia first approach, even before you make your femoral cut, you can, if you want, balance the ligaments. And if you don't want to balance the ligaments before you do your cut and you want to balance the ligaments by making the femoral cut, what you can do is now make the cut based on the tilt and correct the femoral rotation in before you make any ligament releases. So some surgeons not only want to balance the median and lateral compartments, but also want the knee to have a certain envelope of laxity. They don't want the knee to be too tight. And these surgeons will range the knee in varus valgus in addition to flexion extension to see how much laxity the patient will have postoperatively. And so the device also gives you a measure of what the varus valgus laxity is of that knee. A less balance in the AP direction is not commonly addressed. And that's because it's difficult to see the imbalance in the AP direction. And here's a knee that looks extremely well balanced in the medial-lateral direction, but you can see it's tight in the posterior direction. So there's about a 4.6 degrees of tilt in the posterior direction. And that's really difficult to see because it's you cannot see that tilt through the surgical approach. And 5 degrees of tilt is very difficult to notice, but the device actually is very sensitive and picks this up. There are many ways that you can tackle tightness, a knee that's tight posteriorly. And some surgeons will actually put in a thinner insert so that they get enough laxity in a draw test with the knee flexed. Other surgeons will try and release the PCL from the femoral attachment, and you can do that with the device still in place. And I don't recommend this technique, but one surgeon actually was pie crusting the PCL and then watching the correction and knew when to stop. So we now have, for the first time, the ability to measure and record balance in multiple ways intraoperatively. What we're doing is now linking the intraoperative balance to postoperative function. And our hope is that we might be able to identify clinical outcomes that are positive and actually come up with patterns of balance that are appropriate for each patient. When I started research in total knee arthroplasty, it wasn't quite as successful as it was today. And some of the problems that we were facing were stiff knees postoperatively. Wear was an issue at that time in polyethylene. Implant loosening was more common than it is today. And there were cases of osteopenia or stress shielding. The underlying mechanism for all of these so-called complications were knee forces. So what we decided was to actually measure knee forces in patients after knee replacement. And in 2004, Dr. Caldwell implanted the world's first electronic knee. And this electronic knee had a microprocessor, had sensors, had an internal coil that could charge the prosthesis, and had an antenna that would transmit the data. The way this device worked is that an external coil would generate current in the internal coil and power the prosthesis. Once the electronics were powered up, any forces being transmitted across the tray were measured by sensors inside the stem, and then the data was then transmitted wirelessly to a computer that could read the data in real time. So we collected knee forces over a whole range of activities over 15 years. And we started off by post-operative day 1, and since patients have different weights, we reported the results as a fraction of body weight. So you can see that just lifting a patient's leg passively, you do generate forces in the knee. And when the patient does it actively, there's even more force. And when the patient takes his first few steps, even on day 1, he's putting more than his entire body weight on that knee. We monitored knee forces over several years, and we found that they began to plateau by about 6 months. We looked at other common activities of daily living, climbing up and down stairs, getting up from a chair, deep flexion exercises like the lunge, and even kneeling. We looked at exercise equipment, stationary bike, and even upright bikes in the laboratory, and obviously heavily instrumented with force plates and motion analysis equipment. For outdoor activities, we looked at golf and we looked at tennis. Now, when you take all this data together, we also looked at indoor exercise equipment and essentially put the patients through pretty much every equipment that you can find in a gym. And plotting all the data on one chart, you can see where these knee forces rank in terms of risk to the prosthesis, assuming that high forces are bad for implant survival. And some of these results were intuitive. We knew that jogging and tennis were high impact sports, but some of them were not intuitive. We didn't realize that golfing, even though it's not a high impact force, you can put forces on your forward knee that exceed 4 times body weight. And on the safe side, we were pleasantly surprised that biking and kneeling, which although we thought would have higher forces on the knee, didn't have as high forces as we were expecting. Now, obviously, these are laboratory exercises, and this isn't road biking outside the lab. We next looked at modification of force. Could we reduce or modify forces by using orthotics or unloading braces? We even taught patients how to change their gait so that they could reverse the medial compartmental forces, for example, that associate with a medial thrust gait. And finally, we looked at rehab and equipment that would be safe for the patients to exercise in. And one example is the so-called anti-gravity treadmill. So this treadmill has a pressurized chamber, and the pressure in the chamber lifts the patient up. And by adjusting the pressure, you can adjust the amount of force that the patient walks with on the treadmill. So you can exercise patients at, say, a partial body weight of 25%. And so we looked at a whole host of treadmill speeds and treadmill slopes, and we correlated all of these with the knee forces, which is on the y-axis, is multiples of body weight. We came up with a regression equation that could predict the knee force just based on the speed of the treadmill with a probability of over 75%. What can you do with the data apart from just measuring the forces? One way of broadening the application of the data beyond the patients that had these electronics knee, because we could not do a large study, was to use the data to drive computer models. So we developed a finite element model of a total knee replacement. And we took the data from patients. For example, in this patient, he's walking on a treadmill with fluoroscopic data. And so we're now capturing not only the motion of the implants, but also the forces being applied. And we can use that now as input into our finite element model, which takes snapshots of all these activities and looks at, for example, in this case, polyethylene stresses. So despite the fact that I said that lunge had low forces on the tibial tray, but it turns out that if at this flexion angle of 136 degrees, and this is not a high flex design, therefore the rim, the posterior rim of the femoral condyles, now digging into the polyethylene with the potential to cause risk of damage to the polyethylene. And as another example, we used the same model, but included bone and looked at stresses in the bone. And by looking at the stresses in the bone, we could find out what volume of bone was being stressed to the point above its threshold for fatigue and might put that particular patient at risk for tibial subsidence. Now, there's hundreds of models of knees, replaced and natural knees, ranging from just simple models of a knee joint all the way up to um, models of the entire body. And these models, even for activities as simple as walking, sometimes predict knee forces that range from 2 times body weight all the way up to 7 times body weight. So obviously, all of these models can't be accurate. So what we decided to do was make our data sets publicly available. So we released all the patient's medical imaging, including pre-op MRI, pre-op CT scan, post-op CT scan, the computer models of the implants, all the motion analysis data, EMG, and even the force plates and force sensors that we were measuring, and made them publicly available on a website at Stanford. The goal was to encourage students that were developing models to validate the accuracy of the models. And the way we did it was we hosted annual grand challenges, and every year we would release all the data that we had except for the knee forces. And musculoskeletal modeling teams from all over the world would send in their predictions. And at the end of the year, we would pick the winner that came closest to the actual experimental data that was measured. And you can see the amount of interest that we've had across the globe in terms of downloading our data and competing in this grand challenge. And we've actually had 6 of them so far. Unfortunately, you can see that India is underrepresented, at least in the musculoskeletal modeling. So now we look at what I just presented, and all of this looks very artificial. All of this data was collected in the laboratory. We bring the patients in, we train them how to do the activity, we coach them, we put all this gear on these patients, and then we publish this data as if this is what patients do every day in their lives. And this is an extreme example, but look at this patient. I mean, he's on a treadmill, we're doing fluoroscopic analysis, got EMG, he's got motion sensors, video motion skin markers, and we then publish his knee forces saying this is how patients walk. So the question is, what do patients do when you're not monitoring them? What do patients do when they're not in the laboratory? And to do that, we had to take our equipment, and this was over 20 kilograms, and then miniaturize it so it could be worn on a belt. And when we gave these to patients, now patients were relatively untethered and could go outside the laboratory, and we could monitor their data. So once we did that, we then sent these patients and just gave them general instructions. For example, go out and hike, and they would hike, and then they would do things that we never expected them to do. So when we took all this data, you're looking at the forces now measured indoors in a laboratory, a little over 2 times body weight, which is relatively low. But when they are outside, forces now begin to change depending on the surface on which they're hiking, whether they're hiking uphill or downhill, whether they're hiking in grass or whether they're hiking in sand. And here's that one incident of tripping, which generated the highest force that we've ever recorded, over 5 times body weight. So, this begins to question the validity of data that's been collected inside the lab. And I think we need more unsupervised remote monitoring to make broad conclusions. Here's another example of collecting data outside the laboratory. This is a patient who is skiing, and just like walking, different skiing activities actually generate different results. So here you can see that skiing at a beginner level, at relatively easy slopes, the green slopes, doesn't generate as much knee forces. But now when you're getting up into steeper slopes that approach a black diamond, you're now approaching about 5 times body weight, putting 5 times body weight on your knees. So where are we now? It's been 15 years since we implanted the first patient, and our third generation electronic knee is not in patients yet. But this design has onboard power. It has data storage. So what both of these now enable remote monitoring. We don't have to tether the patient to an external power device. We don't have to tether the patient um, to a radio that communicates with a computer that has to travel with the patient. The data is actually in the instrument itself, in the implant itself, and can be pulled out later as needed. Um, our target is a Japanese patient population because of the high flexion activities that these patients do that we were unable to collect in our Western population. In addition to forces, we also have now inertial sensors that can measure range of motion, so we can get kinematics and kinetics all inside one device. Implant stability and perhaps even loosening. So here's an example of the patient population that we're interested in, and these patients have not been implanted with the electronic knee, but have been implanted with Smith and Nephew's bicruciate retaining knee. Again, a new design that keeps both cruciate ligaments intact, and so they have an intact ACL. And we wanted to know what happens to these ligaments when these patients undergo these deep flexion activities. So we did pre-op CT scans and then post-op CT scans, and then conducted fluoroscopic analysis, both pre-op and post-op, while they were squatting and sitting cross-legged. We used a software program called the Vivo Sim, and it's difficult to see on the slides, but where you might visualize the ACL and the PCL, you can see some red lines. And the software program generates computer models of ligaments, then calculates the forces on the ligaments. So here are the two bundles of the anterior cruciate ligament, and you can see the forces are more active in the early range of flexion, which is similar to what you expect. And then here are the two bundles of the posterior cruciate ligament, which gets activated more in flexion, again, close to what you would expect intuitively, but you begin to see really large forces in some patients approaching 800 newtons. So this now begins to open up areas where we can start seeing the looking at implants that have not only the collaterals intact, but also the anterior cruciate ligament intact, and whether this is feasible, whether these knees are going to be more stable, and most important, whether they would survive as long as traditional implants. Now, in the last 14 years, there's been tremendous improvement in electronics. And so our power requirements have gone down 1,000-fold. It went from milliwatts to microwatts. What's the advantage of this? It now opens up the potential for self-powered devices. You can now use energy harvesting. And so in collaboration with the State University of New York, what we are using is using a phenomenon called triboelectric harvesting, where the friction generates static electricity. And with each cycle of walking, the compression in the implant actually generates a small charge, which is then harvested and used to power the implant itself. And at the present, we're not in patients, obviously, but we now have an implant design that can be placed in between the polyethylene and the tibial tray. It requires no external power once it's implanted. Ortho Sensor is also working on a commercial tibial tray that's been instrumented. And their sensors are unique. So in addition to force, they're looking at sensors that can detect infection, that can measure strength of the bone, and that can also be placed in between the bone and the implant. And so they can do an interface analysis. Another company, Canary Orthopaedics, is partnering with Zimmer and putting out a commercial tibial tray that's similar to what we have. At the moment, they're only measuring motion and not forces. So hip and knee arthroplasty are by far the commonest joint replacement surgeries, but shoulder, ankle, elbow, wrist, and hand are also emerging, and the complications are much higher in these joints than in the hip and knee. So at Scripps, what we're doing is developing an instrumented shoulder prosthesis. Here's a long stem that we've instrumented with sensors placed in the neck and with the electronics in the stem. The long stem has plenty of real estate for electronics. And then short stems are becoming more popular. So we're now customizing a short stem design to take our electronics so that we can monitor differences in the performance of these two designs. We're also looking at instrumenting the glenosphere in a reverse shoulder arthroplasty, and also now stemless designs are becoming an emerging interest. On the wrist, we are collaborating with Brown University with their total wrist arthroplasty implant design. And here the challenge obviously is fitting all the electronics within the small radial component. And so we've customized the radial component to hold our electronics. And what we have done is created a capsule that encapsulates our telemetry electronics and put these sensors on a tube inside the radial component itself. This is a new frontier for us, replacing the trapezium in CMC joint arthritis. And this is a technical challenge. We are using a polymeric implant design, and the two implant sensing devices designs that we're looking at is a sensing tube that has sensors inside the tube and a diaphragm where the sensors are under the diaphragm. Well, we're not sure yet which one of these are going to be feasible. And other challenges, for example, loading the base of the thumb is a challenge, and we have to use robotic arms to calibrate these devices, calibrate these sensors. So where are we now? What is the future? I mean, we've made tremendous strides in sensors. Electronics, there have been, the electronics have become more sophisticated. Power is no longer of much concern now, and we believe that we can do remote monitoring. And artificial intelligence and machine learning is now developing to the point where it can make use of all the data that's being collected. So where's the tipping point? When does smart implants become as common as smartphones? And perhaps this pandemic would be the nudge that we need to get to that tipping point. So I'll end my talk right now with this prediction that we will be seeing a paradigm shift in how patients are being treated. I just don't know when that's going to happen. And smart implants are going to become as commonplace as smartphones. I'd like to acknowledge my friends and colleagues. Suri, who actually was my senior at Sion Hospital and was one of the reasons why I decided to pursue orthopedics in residency. Abhay Narvekar, who was my lecturer when I was a resident and taught me most of my surgical skills. Dr. Lad, who was an exemplary professor, a great surgeon, and also a tremendous athlete. CJ Tucker, who helped me in my practice, and I used to learn from him by assisting him in his practice. And Dr. Caldwell, who gave me a job in research and taught me all the research activities and has been a huge mentor for me in the US. I'd like to shout out to my friend Shantanu, who joined me as a research fellow in my laboratory, but is now a professor at SRM Institute of Technology. Shantanu actually collected most of the data on the smart implants and smart instruments that I presented. Thank you again. Appreciate this great